Endocrine disorders. Remember the negative feedback loop of hormone control. You have your releasing factors from the hypothalamus that go to the anterior pituitary that sends off stimulating factors, hormones that go to the gland. Then the gland sends off the hormone. It circulates the hypothalamus, senses the increase in hormone levels, stops sending the releasing factors, and that's why it's considered a negative feedback loop. Please make sure that you understand that. When you have somebody who has an endocrine disorder, you need to get their history. When did the symptoms start? What were they like? How long have they lasted? What's their patient profile? Age, risk factors, all sorts of lovely things about that you need to know. What are their risk factors? What's their family history? What prior medical tests have been done? And what are their current medications? Normal A&P, since it's probably been a while since you had this, I'm going to review it. The pancreas, as far as the hormones are concerned, the major area are the islets of Langerhans. These contain 4 cells. Your alpha cells that contain glucagon, your beta cells that produce insulin, thereby decreasing fat stores, whereas your glucagon raises your blood sugar. Your delta cells that contain or produce somatostatin, which lowers your blood sugar and decreases the amount of glucagon that's released, so thereby you don't need as much insulin. And your PP cells, which are your pancreatic polypeptide hormone, and they don't really know what they do yet, but they're working on it. So we'll have that to come very shortly. Insulin is produced by the beta cells. It is done to lower your blood sugar, decrease your immobilization of fats, increase your potassium into the cell, stimulate protein synthesis. Insulin is required for transport everywhere in the body except into the brain. And one theory for that is that the brain may be producing its own insulin. Also, with exercise, insulin transport is facilitated. In other words, instead of only taking one glucose molecule with it, it'll take 3 or 4. So exercise will lower your blood sugar. The hypothalamus contains releasing factors, ADH, which is your antidiuretic hormone, responsible for constriction of smooth muscle and maintaining the osmolality of the blood. So it saves water. It's antidiuretic. And oxytocin, which you'll learn about next semester when you do OB. Your anterior pituitary gland releases ACTH, which is adrenocorticotropic hormone. You need to know what it stands for because it tells you where it works then. So it goes to work on the cortex of the adrenal gland, causing the release of cortisol. TSH, which is your thyroid stimulating hormone. FSH, which is your follicular stimulating hormone, and again that's next semester, as well as the luteinizing hormone for next semester. Your growth hormone and prolactin, again prolactin next semester. Your posterior pituitary stores the ADH that's produced by the hypothalamus and will release it when the osmolality of the blood goes up. So, or when your blood pressure goes down. So hypovolemia, hypotension, and hypernatremia will cause an increase in ADH production. The thyroid gland releases T3, T4, which together are your active thyroid hormone, and TSH, just a small amount. And calcitonin. Now calcitonin decreases calcium levels very rapidly, within an hour. And you can give calcitonin exogenously. You can also give T3 and T4 exogenously as thyroid hormone replacement. Your parathyroid gland releases your parathyroid hormone, which promotes calcium conservation and phosphate excretion. So parathyroid hormone does the opposite of calcitonin. Your adrenal gland releases cortisol, aldosterone, catecholamines, and your androgens. On your physical exam, the only gland that you can actually, we can't actually inspect any of them, but you can look for signs and symptoms of either an increase or a decrease in your basal metabolic rate, which is your thyroid, or changes in your neuromuscular activity, which would be your calcium and your parathyroid, or changes in your cortisol levels or your catecholamine activity, and again, that's your adrenal, or for changes in your blood sugar activity, which would be your pancreas because of diabetes. Palpation, the only gland that is palpable is the thyroid gland. And to palpate the thyroid gland, you stand behind someone, at least I do. Put your hands on both sides of the trachea and ask them to swallow. And you will feel the isthmus of the connection of the thyroid gland go up and down. Okay? And you can identify the size of the gland. Percussion is not really an option for the endocrine system at all. Auscultation is only for the thyroid gland itself, because the thyroid gland is extremely vascular, and it has 5 different arteries that supply it. So if the blood flow has increased to the thyroid gland, you will hear a bruit, which is like a murmur or a blowing sound, a type sound. For the pancreas, the diagnostic test you'll do would be your fasting blood sugar, which should be between 70 and 110. Your hemoglobin 1C and A1C, which should be around 6.5, which would work out to about an average blood sugar of 125 to 135. Your A1C, your glucose, and the nice thing about your A1C is it will tell you your blood sugar for 3 months, your average blood sugar for at least 3 months, because glucose binds permanently when it's elevated to your hemoglobin molecule, and your red blood cell survives how long? Hopefully you said 120 days. And a glucose tolerance test, anyone who has been pregnant has had one of these done, usually I think around 28 weeks gestation, to check to make sure that you're not gestational diabetic. And it should be normal by hour 3. And this is when you drink a high carbohydrate load. Now they're supposedly flavored, like chocolate or orange or whatever, but they don't taste good. It should be totally normal by hour 3 after that high glucose load. Now 2-hour postprandial blood sugar, on the other hand, should be normal by hour 2. And the tighter the control you have on your blood sugar, the better your patient does. There are fewer complications. And when the patient's in the hospital, they still want to keep that blood sugar around 140 or less. If it's a metabolic problem, they want to keep it around 140. If it's a surgical problem, they want to keep it between 110 and 140, because it tends to decrease on their mortality and morbidity. The pituitary gland, you're going to assess their hydration status, because after all, we're talking about ADH. The labs you're going to do a serum ADH, your urine and blood osmolality, and maybe a water deprivation test to see how the body responds. You can do a CT, MRI, or skull series, because the pituitary is in the skull area. The thyroid gland, you'll do a T3, T4, T7, and TSH. Now TSH they're looking mainly from the anterior pituitary. You need to be aware of drugs that influence thyroid function. For example, aspirin competes with your thyroid hormone for protein binding sites. So if you take a lot of aspirin, you're increasing the amount of free thyroid hormone that's out there. If you are taking lithium for any reason, that decreases the amount of thyroid hormone you have available, and so you could become hypothyroid. So you need to know what sort of drugs your patients are taking, and of course why they're taking them. And you can palpate and auscultate the thyroid gland, as we've already discussed. The parathyroid gland, is responsible for your calcium retention and phosphorus excretion, so you're going to do a calcium and phosphorus blood level. And again, pardon me, your parathyroid is in the neck. You have 4 to 6 glands. They are some of them are embedded in your thyroid gland. Some may be in your upper chest cavity near the thymus. So you want to do a CT scan or an X-ray to see the number of glands you have and what they look like. The adrenal gland, you would check for your serum cortisol levels because the adrenal cortex secretes cortisol. Your urinary 17-hydroxycorticosteroids and urinary 17-ketosteroids are looking at the end products of cortisol metabolism, and you need to use care because some of these have acid in their 24-hour urine tests. And we'll talk about them more when we do your case studies. And the dexamethasone suppression test is looking to see if you have somebody who's overproducing cortisol. And you would give this at midnight and then check levels at 8 because your cortisol secretion is cyclical and it goes along with your circadian rhythms. So you have twice as much in the morning as you do at 4 in the afternoon. A urinary vandelic acid, or VMA, is done to assess for a pheochromocytoma. And we need to, and then there are certain drugs that have to be stopped when you're doing a urinary VMA and certain dietary restrictions. But again, you're looking at increases in catecholamine levels type things. You could do a CT of the abdomen also to look at the adrenal gland. And keep in mind that vitamin D is necessary for calcium reabsorption, or calcium absorption from the gut. It's called the sunshine vitamin because our body produces it and then it's activated by sunshine. And if we don't have enough, we get osteoporosis, among other things. So the official recommendation is to get 400 to 800 international units daily of vitamin D. But some experts think that should be set much higher, particularly in the wintertime when there is not a lot of sunshine. So we need to increase our vitamin D levels. Thyroid medications might be calcitonin because calcium, it will lower your serum calcium levels in 60 minutes and can be given IV or IM. Your thionamides, like tapazole or PTU, which is propylthiouracil, are given to decrease your hormone synthesis. They cause an allergic reaction called agranulocytosis, and the symptoms of agranulocytosis are hopefully you filled in fever, sore throat, and a rash. Because when you have agranulocytosis, you have an absence of your granulocytes, which are your eosinophils, your neutrophils, and your basophils. Your iodine preparations, such as your saturated solution of potassium iodide or Lugol solution, are given to decrease the vascularity of the gland, firm it up, and decrease the release of the thyroid hormone into circulation. So it's oftentimes given prior to surgery for about a month, as well as the tapazole and PTU are given for about a month prior to surgery. Iodine tastes terrible, and it can permanently stain your teeth purple. So you want to give it through a straw to get it past the teeth. Now, we're not talking huge amounts. When you're talking saturated solution of potassium iodide or Lugol solution, you're doing like 5 drops or 10 drops of this liquid. Now, I think your textbook recommends putting it in milk. Then you got gray milk to drink. Why don't you put it in grape juice? It's already purple. Grape juice is purple. You're not going to notice the difference. And it does help to mask the taste. Lithium carbonide is given to decrease the synthesis and the release of the hormone. But it can cause depression, tremor, nausea and vomiting, and can cause you to become hypothyroid. It's really important that you remember that, particularly when you're dealing with patients that have bipolar disease. You may think that they're just depressed, and it could be that they just have too much of the lithium on board and are hypothyroid as a result. And of course, hormone replacement therapy. You can have generic or Synthroid. Now, generic and Synthroid are not really interchangeable, but there is a generic form of Synthroid now called levothyroxine that is the same. So you want to take the hormone before breakfast. Keep in mind that if you're taking Synthroid, it does contain lactulose, and if you're lactose intolerant, it will be a problem. And it does interact with anticoagulants to increase bleeding. So you need to be aware of that also. Your goal of care with endocrine disorders are to promote return to homeostasis. And to do this, you want to promote appropriate hormone levels, maintain adequate temperature levels, maintain adequate fluid and electrolyte balance, safety and mobility, your vital signs within accepted limits, and appropriate blood sugar levels. Different calls for nursing include decreased cardiac output, hyperthermia, impaired gas exchange, altered nutrition either more than or less than body requirements, activity intolerance, altered home maintenance, body image disturbance, knowledge deficit, potential for injury, sleep pattern disturbance, and anxiety, just to name a few. Usual medical treatment: if you're hyperthyroid, the medication, you may be on medications. You can be told you'll be on medications for the rest of your life, like beta blockers to control those symptoms. The Tapazole or PTU might be given. You could have surgery. Usually they'll remove 2/3 of the thyroid gland because it's 2 lobes, so they'll take 2/3 of each lobe, and that prevents hypothyroidism theoretically. Or you could take radioactive iodine. Now this can be given as an outpatient. It takes about 6 weeks to 6 months to take effect. During that time they're still hyperthyroid, so they may need to be on some of the other medications. And you need to use care for several days after taking radioactive iodine, which is given in the doctor's office. No kissing, no intercourse, don't hold any children or babies for several days. Make sure you flush the toilet 2 to 3 times each time you go. Separate linens and your kitchen utensils. Increase your fluid intake to help flush this out of your system. And no, you don't become radioactive. I'll give you a brief story. I was 21. Brand new graduate from nursing school, working 11 to 7, because that's where the only jobs were, in ICU, because that's where I wanted to be. And that was an CCU combination type unit at St. Luke's. And one day I went to the movies with my mom, and we went to see Butterflies Are Free. Now, it is not a black and white film. I'm not quite that old. And it is a very funny film with Goldie Hawn and Edward Albert, where he's blind and she's not, and she doesn't know he's blind, and it's just very funny. It was also a Broadway play. I highly recommend it. But anyway, I sat there and laughed at the film. When we got out of the film, I said to my mother, "Wasn't that a funny film?" And she said, "I don't know, you're going to the doctor." I said, "I beg your pardon. Wasn't that a funny film?" She said, "I don't know, you're going to the doctor." And I said, "No, why am I going to the doctor?" She said, "Because your heart rate's 140 and you're breathing 40 times a minute." And I said, "No, I'm not." She said, "Trust me, that's all I've done for the last hour and a half is count your heart rate and your respirations. You're going to the doctor." Well, you know, when I stopped to think about it, for the first time ever, I was able to lose weight without a whole lot of effort. And I was sleeping maybe 4 hours a night and still feeling energized. And I was getting an awful lot done. And I went to the doctor, and he said, "You have 2 choices. We can put you on medication for the rest of your life." Well, actually, you have 3. Give you radioactive iodide, which I don't really recommend, and I didn't want anyway. He said, "Or we can remove 2/3 of your thyroid gland, and you won't have to be on any medication." Well, I don't like pills, so I had surgery, and if you want to see the scar that's left over, just ask me. I don't mind showing you. It's in my neck crease. And I had surgery. Did really well for 3 months. Then I was sleeping 12 to 14 hours a day. I was looking at water and gaining weight. I didn't even have to drink the stuff. I went back to my surgeon, and he said, "Oops, might have removed just a little bit too much." So now I take medication every day of my life. I was on Synthroid, now I'm on levothyroxine. Synthroid has a half-life of 6 to 7 days. Most of your thyroid hormone replacements have long half-lives, so you only have to give a little bit of it. And it does take about a week to 10 days to get it up to snuff. So the major treatment for hypothyroidism is hormone replacement therapy. And diet and activity modifications, because it's really easy to gain weight with somebody who's hypothyroid. Hyperparathyroid, the medications are calcitonin, which I've already said can be IV or IM. Maybe your phosphates, either IV or oral, or you can give it as an enema, your Fleet's Phosphosoda. Now, that Fleet's Phosphosoda can be taken orally. I strongly recommend you put it in a glass before you take it into your patient. It's not really aesthetically pleasing to take it out of an enema container, pour it into a glass, and say, drink this. Just doesn't cut it. Steroids will be given to decrease your vitamin D and A. Decrease your vitamin D and reduce your calcium absorption and bone resorption, so that you shouldn't get osteoporosis. Cytotoxic antibiotics can be given to decrease your calcium and phosphate. And it's really important that you get your patient up and walk them. Do weight-bearing activities. If you're hyperparathyroid, you need to push that calcium back into the bone. So get them up and move them. They may need diuretics and they may need salt tablets. And if they need salt tablets, they need to drink at least 3,000 milliliters daily to go along with that. They can also have surgery to remove some of the parathyroid glands and Hypoparathyroidism, on the other hand, you're going to administer IV calcium chloride or gluconate. You'll give vitamin D and oral calcium supplements. No saline or sodium bicarb if you are hypoparathyroid, because they bind with your calcium. Type 1 diabetes requires insulin. It's 5 to 10% of the cases. Type 2 is about 90 to 95% of the cases. Diabetes in and of itself in 2002 cost $132 billion to treat. The CDC says 9.4% of the expenditures are for obesity and low activity, and that it increases our death rate by about 33%. If you're type 1 diabetic, you have to have blood sugar checks at least before your meals and bedtime, and sometimes more often. You need to treat dehydration and electrolyte imbalance, because high blood sugar makes you dehydrated. And you need to treat the hypoglycemic events, because hypoglycemia kills brain cells. So if your blood sugar is 40 or less, you're going to give them simple and complex carbohydrates between 40 and 60. Patient's still alert, but you're hypoglycemic. So you're going to give them a simple and a complex carbohydrate, because if you only give them a simple carbohydrate, their blood sugar will drop again. And it's a yo-yo effect. So you give them a complex carbohydrate with that. If they're stuporous, you give them some IV glucose, or you give them some IV glucagon. And there are different ways to deliver insulin other than sub-Q or by injection. They are researching insulin pills and capsules that they think can deliver insulin into the bloodstream within 30 minutes. So far it's being destroyed by the gut, but they're working on it. They have an insulin spray, which is a powder that goes in by the inhalers. That's Exubera, and that is available, but the company wasn't making the money they thought they would, so they're trying to sell it to somebody else. So unless you're already ruled taking it, you cannot necessarily get a hold of it. They also have a patch that passes insulin steadily through the skin that they're working on. But it's a whole lot easier to prevent diabetes than it is to treat it. And keep in mind that if you have a McDonald's double quarter pounder with cheese, that's 780 calories for one sandwich. If you have that Hardee's Monster Thick Burger, that's 1,420 calories and 107 grams of fat for one hamburger. So you need to think about that. Type 2 diabetes, the major thing you want to do is prevent the complications of microvascular and macrovascular disease. Microvascular disease affects your eyes and your kidneys, where macrovascular disease affects your blood vessels, causes things like heart attack and stroke. Medications that are given for type 2 diabetes are your sulfonylureas, which stimulate your beta cells to produce insulin. They have your biguanides, such as metformin, which are glucophage, which lowers your blood sugar by decreasing glucose formation and uptake and increasing insulin sensitivity. You have your alpha-glucosidase inhibitors, such as Precoce and Glycate, which prevent glucose absorption. They have to be given with a meal. They do cause diarrhea, sometimes severe diarrhea. So you have to be careful about that. They have your thiazola. I got to do this fast, and I never can. Thiazolidinediones, such as rosiglitazone or Avandia, which decrease insulin resistance that you want to give. They also have some new ones. You've got a DPP-4 inhibitors, sitagliptin or Januvia. This increases insulin production and decreases the liver's production of glucose. You need to take it once a day with or without food. And you've got your meglitinides, such as Starlix or Prandin, that increase insulin production by the pancreas. You take it right at the beginning of the meal, and it doesn't cause any weight gain. Sulfonylureas do. And then you've got, different combinations of the pills that you can take also. So, and they're always working on new drugs that are out there. They have some incretin inhibitors that make you feel full and decrease the amount of fluid that are glucose that you need to take in. Okay. Cushing's syndrome or Cushing's disease. Cushing's syndrome, if it's iatrogenic, that means it's because of something you're taking. It's going to be a steroid. Stop taking the steroid. If it's due to a tumor, remove it. You need to administer medications to decrease your cortisol production, such as Cytodren or Midotane. You need to administer meds to lower the blood pressure or increase your potassium levels, such as aldactone or spironolactone. You need to prevent falls and infection and increase their activity tolerance and promote effective coping. Keep in mind, aldactone is a normal mineral corticoid that is related to chemicals in our body. Addison's disease. Remember, Cushing's, you have a huge cushion of cortisol. Addison's, you need to add some cortisol. And the medications you need to add is cortisol. Hydrocortisone, if you need to inject it in a hurry. You need to avoid stress. Maintain a regular schedule. And this is lifelong therapy. Now, a pheochromocytoma is a tumor of your adrenal medulla. And it's fairly rare, tends to affect only one gland rather than both. But they will secrete your catecholamines, your epinephrine, norepinephrine, and a small amount of dopamine. So you need to make sure that the drugs you give will be given to lower the blood pressure, such as dibenzoline, which is a long-acting alpha blocker, or propranolol, which is a, hopefully you know, beta blocker. Regitine, another alpha blocker, or nipride, which is a very potent vasodilator. and you need to, they may need to surgically remove that gland. If so, the patient's usually on nipride and dibenzoline part 2, because you want to prevent increases or bursts of hormone release from the gland, the endocrine from catecholamines from the gland. This finishes the endocrine lecture, and if you have questions, please let me know. Thank you.